Well, that is a perfect segue to a discussion about adverse events and deaths reported from the COVID-19 vaccine. And Dr. Seheult, could you explain what VAERS, or the Vaccine Adverse Event Reporting System that we use in the United States, is, and how that data should be interpreted?
Yeah, thanks, Kyle. So to back up a little bit, let's talk about a 6-month period of time here. So if we look at December, January, and February of just a few months ago, that was a period of time, at least where I'm working in Southern California, where there was a lot of COVID. In fact, we had to build an entire new ICU with isolation precautions. We had to have nurses trained. We basically used a lot of resources because surgeries weren't happening at the time. And compare that with the next 3 months after that, which would be March, April, and May. So the reason why those two groups of 3 months are very different is the first group of 3 months had a lot of COVID-19 patients coming in. We were very full. And then after that wave went away, we basically disbanded the second intensive care unit. We were able to contract back to what we were doing before. And this, despite the fact that in March, April, and May of 2021, we were vaccinating millions of people a day. And so, again, I just want to underline what Dr. Patrick was saying there. If this spike protein from the vaccine was so dangerous, how were we able to contract down our hospital ICU intensive care services during that period of time? However, what did happen during that time was that there was a huge spike of, so the argument may be made, for instance, that maybe the spike protein is not causing disease or conditions that would get people into the intensive care unit, but it might be causing more mild symptoms or more mild problems. And that might show up in something called the VAERS system. So let's talk about the VAERS. So as you can see here on the screen, there's this chart that is made the rounds on the internet. And what it does is it shows the total reported deaths post-vaccine. And you can see, obviously, not post-COVID vaccine, because the COVID vaccine didn't exist back during these years. And we're going back way back. And then all of a sudden, there's this huge spike here. And these, again, are reported deaths. So this is evidence, some say, that these patients that are receiving the COVID-19 vaccine are dying. So again, I don't know how they could be dying without going through the intensive care unit. I guess it's possible they could be dying at home and never making it to the hospital. So let's investigate exactly what it is that's going on here. The thing that you've got to understand about this reporting system, a couple of things. Number one, you have to understand that because the vaccines that were given emergency use authorization in 2020, late 2020, because of this, they expanded the reporting requirements for the VAERS. In other words, before, a physician would make a report to the VAERS if he suspected that a vaccination led to a death and they were under suspicion that something was connected. Now that was completely eliminated. Now, no matter what happens, if a patient gets a vaccine and anything happens, hospitalization, death, anything, it should be reported under law. So I wanted to take a look at this a little bit more. And what I did was I looked at this paper that was published back in 2016. And it was looking at the flu vaccine, because a lot of people say that this has never happened before. This huge increase in reporting from the vaccine has never happened. But yet there is a situation that occurred, and it was published here in December of 2016, titled Surveillance of Adverse Events After Seasonal Influenza Vaccination in Pregnant Women and Their Infants in the Vaccine Adverse Event Reporting System, July 2010 to May 2016. So as you may recall, in 2009, we had a flu epidemic called the swine flu epidemic. And in that year, there was a huge amount of H1N1 influenza. And you can see that here on the screen with that red bar. So you can see the blue is sort of the endemic influenza. And then in 2009, this massive increase in H1N1 reports. And so what you also see here is that purple line is the amount of vaccinations that happened. So because there was a lot of influenza that was going around, a lot of people were being vaccinated. So what you're actually seeing here, these bar graphs, is the number of reports of adverse events. Okay, so that's key to understand that. Even though the vaccine had not changed, the makeup of the vaccine had not changed, what we saw was, because there was more vaccinations being given, there were more reports being given. But there's something actually more to it than that even still. And that is that there was more understanding and more awareness of influenza. So what I've done here is I've superimposed Google Trends. So how often somebody would get on the internet and search for influenza. You can see clearly there at the same point in time that we're seeing increased reported spikes, we're seeing an increased interest in influenza in general. In fact, the highest that there ever was during that time, because it was a very important news item at that time. Now, again, this was under strict reporting system. So they only could report whether they felt that there was a connection. But even that, after they looked at it and published this paper, this is the conclusion that they came to. Despite the increase in reporting events, they said that the peak in the number of pregnancy reports observed during 2009 to 2010, followed by a decrease in reporting, suggests that the 2009 spike in pregnancy reports after 2009 H1N1 inactivated vaccines may have been due to stimulated reporting. In other words, the vaccine hadn't changed, the side effects hadn't changed, and so their conclusion was that as in 2000 and 2009, 2010, no new or unexpected patterns in maternal or fetal outcomes were observed during 2010 and 2016. So if we take the same kind of methodology that we've done, we've looked at this huge spike here with COVID-19, and this is supposed to be evidence that people are dying from the COVID vaccine. We see a very interesting pattern, because if we look at Google Trends and we type in COVID vaccine, obviously there's a massive spike at the same time, the same kind of recipe that we would see with the influenza. And then also, just to make sure that we understand here, this is the deputy director for the Centers for Disease Control. And this is what he says. He says, quote, healthcare providers reporting requirements are much broader than for other vaccines. After someone receives the COVID-19 vaccine, their healthcare provider is required by law to report all serious adverse health events. That would include death, even if the provider does not think the vaccine caused that event. These events can include death, inpatient hospitalization, or a serious case of COVID-19. That reporting protocol is due to the fact that the FDA authorized the COVID-19 vaccines for emergency use. So you can see that the rules have changed in the middle of the game. And so we have to look at that. So again, if we were to give a placebo injection, the question is we would still see deaths associated with the vaccine. Why? Because we're vaccinating so many people and because of just chance. So I did a little bit of a epidemiological exercise. So bear with me. If you look at the U.S. death rate per 100,000 population per year, it's around 870 deaths. So in other words, if you were to take at random 100,000 people in the United States and follow them for a year, you would find at the end of that year that about 870 people would have died. Obviously, as the age goes up, that can go up to as high as 4,000. Here in the 75 to 84-year-old age group, that's much higher. So let's just take the average. We'll be conservative. And also, if you were to look over the period of the last 7 months, going from January of this year to August, 7 or 8 months, you'll see that there's a fairly linear increase in the amount of vaccinations over that 7-month period of time. And in fact, over that 7-month period of time, there's been about 166 million people that have been vaccinated. So if that's over a 7-month period of time, the average period of time that someone's been vaccinated is about 3.5 months. And over that period of time, which started in January, that's when we have the highest death rates. But then as we go through the year, it comes down to the lowest death rate. So that's over that period of time. There's an average death rate in the United States. So let's do a little bit of calculating. If there is 870 dead people per 100,000 people per year, and we adjust that for the 166 million people that we've vaccinated in one campaign, and then we adjust that for, instead of 12 months, just 3.5 months, which is the average period of time that people have been on average vaccinated, we come to this number of about 421,000 people that should be dead just by chance from getting the vaccine. And clearly, that's not the number of people that we're seeing. The reports show maybe 10 or 15,000. So clearly, there is a huge amount of underreporting occurring. Now, realize that, again, most of the people who are being vaccinated, at least in the country, are actually much older. So this number should actually be higher. And number two, that most of the people that were vaccinated very early on and therefore have a longer range of vaccination were the older group as well. And so when you look at that, you can see here that the reported deaths totaling about 5,000 or 6,000 is a huge underreporting of the number of deaths that we should have if we just put a little red dot on their shoulder or gave them a placebo injection. And that's very important to understand, because some disingenuous people will show this and say, look, the vaccine is causing these deaths, and that cannot be gotten from that type of data. The other graph that you might see is this graph, which shows the number of days after vaccination that deaths are reported. So based on our 400,000 number that we've come up with, if we were to prorate that on a daily basis, we would come up with about 4,000 people dying on a daily basis on average. Obviously, that gets bigger as more and more people get vaccinated. But what we're seeing here after a vaccination is only 600 to 700 deaths per day. Again, huge underreporting here at this point. So because there's huge underreporting occurring, one might think that what would be the most likely reporting situation? Someone who got a vaccine and died the next day, or someone who died maybe a month later? Obviously, when you have a death occurring close to an event that has to be reported, the reporting is going to happen more likely in that situation. And you're going to have underreporting occurring much more likely a month later. And that's exactly what is demonstrated here with this graph. We see that the most reporting occurs within 1 or 2 days, and then it goes down precipitously, consistent with that type of pattern. The other last thing I'll leave you with here is that with the mRNA vaccines, with Moderna, for instance, it's a 4-week interval between shots. And for Pfizer, it's a 3-week interval. If, in fact, that second shot is causing the problems that we see with myocarditis, myocardial infarction that's been proposed or been suggested, I would expect to see another peak here about 3 to 4 weeks out. But in fact, we don't see any such peak. And so that, again, lends me to believe that this graph is the result of reporting events and human psychology rather than an actual spike protein that's causing deaths in these patients. I agree that we should look for this stuff. This stuff needs to be taken seriously. And that is exactly the purpose of the VAERS system, is to look to see if there are patterns. But to go out and say that simply because there are deaths, that must mean that the vaccine is causing deaths, I think that is disingenuous and not supported by the data.
Dr. Patrick, anything to add to that?
Yes, I do. I do agree 100% with that last statement that Dr. Seheult just said, because people are taking this data that is, accessible to the public from the VAERS system, and they're trying to make sense of that data. But scientists from the CDC and from the FDA analyze that data. They have to look at they have to stratify it by age, by gender, by ethnicity, and see how many people die of X, Y, or Z in that age range, of that gender, of that ethnic group, without a vaccine. Just what's the normal background death rate? And you need to do that comparison. Otherwise, this is like the worst epidemiology data you could ever imagine without any correction for confounding factors. It would be like, one year there was 200,000 births in the city of San Bernardino, and at the same time we had 10,000 storks that flew by. Therefore, storks have to be causing or delivering the babies. Or causing the births, basically. So, epidemiology is a big mess, and so you can't just take that data and make these correlations. And I think to sort of add to what Dr. Seheult's kind of brilliant epidemiology experiment that he just explained, to add to that, in the United States alone, every 30 seconds, someone dies of cardiovascular disease. Every 30 seconds. Now, generally speaking, most of those people are going to be 50 or older, because cardiovascular disease doesn't usually affect people in their 20s or 30s. It can, but generally speaking, it's usually an age-related disease, more or less. And so, if you look at the reported VAERS deaths, more than half of them are in a population of people that are 50 and older. So it's like, well, what are the chances that some of those people are probably just dying from a heart attack or from cardiovascular disease? Stroke, every 40 seconds, someone has a stroke in the United States. They die from it every about four minutes or so. So, there's like Dr. Seheult said, there are a lot of people dying every day in the United States. completely independent of COVID-19, completely independent of vaccines. So it's really not it's not accurate to try to interpret the VAERS data yourself without stratifying it and looking at all the other factors that I just mentioned. But even on top of that, last time I did a VAERS report actually was probably close to a month ago, maybe 3 weeks ago. And at that time, I was stratifying the data by age and looking at the reported deaths. Over 584,000 people of the age of 50 and over have died from COVID-19. And last time I looked at the VAERS, which is about a month ago or so, about 5,000 people over the age of 50 had reported, VAERS deaths. And so even if you were to take that 5,000 and triple it, you're still 40 times more likely to die from COVID-19 than you are from a vaccine if you're over the age of 50. People aged 40 to 49, about 20,000 people have died from COVID-19, according to the CDC website. If you look at the VAERS, it's much lower than that, about 200 people. And if, again, triple that number, even after tripling it, you're 33 times more likely to die from COVID-19 than from a vaccine if you are age 40 to 49. And then bring that age group down even further, 18 to 39-year-olds. About 10,000 people have died from COVID-19 in that age range. And if you look at the VAERS data, it's somewhere around 200. Let's triple it, 600 people. You're still 17 times more likely to die from COVID-19 than from a COVID-19 vaccine if you are in the age range of 18 to 39. So again, at every age group, you're much, much more likely to die from COVID-19 than you are from a vaccine. And that's not even, we're just directly taking the VAERS reporting. And as I said, you can't do that. We don't even know if those deaths are actually causally linked, right? It's correlation. So I think when you look at it like that, it makes a lot more sense that everyone's going to be exposed to the SARS-CoV-2 virus at some point. Do you want to be vaccinated when you're exposed to it? I do, personally.
Okay, let me summarize my understanding of this, and correct me if any of this sounds wrong. In our country of over 300 million people, there is a background number, an expected number of deaths and other medical problems that are going to happen on a daily basis or an annual basis on average. And then we have this reporting system, the vaccine adverse event reporting system, where medical professionals are not only encouraged, but they're actually required to report any medical problem or death that happens after someone gets a COVID-19 vaccine, whether or not they think the vaccine caused it or not. So it's an epidemiologist and other scientists' job to look at the number of reports that come into the VAERS and compare that with the background numbers for each age group and other demographics and assess, does the number of reports actually rise above what we would expect for that age group and other demographics? And in listening to you, Dr. Seheult, it sounds like for deaths reported from the COVID-19 vaccine, the number of deaths actually falls far below the background level that we would expect, which suggests that there's underreporting, but it also suggests it's very unlikely that a significant number of deaths are happening from the COVID-19 vaccine. Do I have that right?
Yep.
Absolutely. And I think just to kind of even add to that, the myocarditis link that we now know about, linked to the mRNA vaccine specifically, came out of the VAERS data. And after the scientists, epidemiologists analyzed the data, they found myocarditis was above that background noise. It was higher. So there was something there. And, I've heard so many conspiracy theories that, the government agencies don't want us to know about it, don't want us to know about the adverse effects. Then I just don't understand why we would know about myocarditis being linked to the mRNA vaccines, or why we would know about rare blood clots in some cases with Johnson & Johnson, very, very rare. If there was some big conspiracy, why would we know about some of the potential rare adverse events, but not others?
It's always powerful when someone knows someone who got a COVID-19 vaccine and then had a death afterwards, or some new onset of symptoms. So what would you both say succinctly to someone who says my parent or grandparent or whoever got the COVID-19 vaccine, and then 3 weeks later, they died of a heart attack. I think that those are linked. What would you say to that person? I'll start with you, Dr. Seheult, on this one.
Yeah, I mean, this is really what makes us human beings. We have to put on our scientific hats when we talk about numbers because we can't be attached to it. And on the other hand, we're also human beings and we live with it. So it's hard to do that. I can tell you that when I'm in the hospital, if I give a blood thinner to somebody because they have a condition and they bleed out and die, and the next person that comes in with that same condition, I'll have to tell you, as a human being, I'm a little bit less gung-ho about giving that person a blood thinner, even though it's indicated and it has and it's the right thing for that person. In other words, what happened before doesn't necessarily tell me what's going to happen again. It's statistics that tells us that. And that's actually one of the fallacies of medicine. So when you're making medical decisions, there's always going to be risks. It's always going to happen. I can tell you that. I mean, don't let anybody tell you that we don't do harm in medicine. We try to do more benefit than harm. We give aspirin to people who have heart attacks. We give blood thinners to people with atrial fibrillation. Are you telling me that we've never had a situation where someone has bled on a blood thinner or someone has gotten an ulcer from aspirin? It happens. But we have to look at the benefits versus the risks. So in that situation, I would tell them that it's possible that whatever they had could be linked to the vaccine, that we have to look at epidemiological studies to see whether that's the case. And I would understand if they were hesitant to get the vaccine in that situation. I would completely understand as a human being, because that's the same struggles that I have as well. But if we want to make policies going forward, we always have to realize that no matter how many times you've rolled the dice and it's come up 6 every time, that the next time you roll the dice, there's still a 1 in 6 chance that it's going to be a 6, despite the previous rolls. So, and unfortunately, that's what we have to deal with when we're looking at risk-to-benefit ratio. Maybe one day in the future, we'll be able to do a better job at predicting who will benefit and who won't. But right now, we do the best that we can.
Dr. Patrick,
I think just to add,
yeah,
sorry.
Go ahead.
Just to add to that, I think, the fact of the matter is that in the United States alone, over 177 million people are fully vaccinated, over 1 billion people worldwide. And, as Dr. Seheult pointed out, people respond to things differently, to drugs, to the foods that we eat every day. If we were to give peanuts to 177 million people in the United States, a good size of people would have a pretty serious adverse reaction. Same goes for shellfish. It's a really big world out there, and there are individual differences in the way we respond to foods, to medications, to vaccines. But it doesn't mean, so, in other words, it's not a zero risk, as Dr. Seheult was saying, but it's also not the 100% of the population is not responding that way. It's not because there's something inherently, for the most part, you can have a medication that is dangerous, but we would know that by now with 177 million people fully vaccinated in the United States and over 1 billion people worldwide. We would know.
Yeah, and Kyle, this is probably a good time to also say that the purpose for Dr. Patrick and myself being on here is really to educate people on what are the risks and the benefits and the relative risks so that they can make a decision. And the reason why we want to arm them with that information is so that they can make a decision. So we're not for forcing people to get vaccines. This is we're not the purpose of saying it's okay to be forced to get these vaccines. We're not really for mandates. We're really here to educate, and I think that's an important distinction. But Dr. Patrick can speak for herself.
Yeah, I 100% agree. I would never want to force anyone to do anything they're scared of. I certainly wouldn't want to force a parent to do something to their child that they were scared of. And I think that the purpose of this podcast and in general speaking about what the data shows about vaccines and COVID-19 is to really help people that don't have the capacity to interpret the scientific literature, to help them have a more well-informed, basically background so that they can make a good decision on whether or not they want to get or choose to get vaccinated. And I think that there are people out there that are not giving good information for whatever reason. To be honest, there's a lot to gain from making sensationalistic claims that something you think is good for you is actually not. So we think vaccines are good for us, but they're not. And you can gain a large following, and there can be a little bit of a perverse incentive in some instances for people that are technically versed in the scientific literature, that may have a degree, higher education, and yet are cherry picking and misleading people. That does happen. And in order to counter that, I think it's important to put an unbiased approach, try to interpret the data for what it is, and also put that information out there.